Welcome. Today we'll be talking about safety as a system, a perspective from the bottom up. A common misconception that we have in quality is that when things go wrong, it's usually because of a dumb doc or a dumb nurse or a sick patient, when in fact, the system largely sets us up to fail. But we're going to talk about that over the next 25 minutes here. Here's a quote from James Reason. I'm a psychologist. I like to quote psychologists. He says, rather than being the main instigators of an accident, it's the frontline workers who tend to be the inheritors of system defects. Their part, as frontline caregivers in this case, as frontline workers, their part is that of adding the final garnish to a lethal brew that has been long in the cooking. Don't you see that every day at the front lines? The system is broken. We're doing our best to function in this broken system, but it often sets us up to fail. So here's a fun acronym if you're an aviation buff, because a lot of the lessons learned from this actually comes from the aviation industry. CFIT. CFIT is an acronym for the most common type of commercial aviation accident that we have. It stands for Controlled Flight into Terrain. About 43% of all accidents are CFIT accidents. What does that mean, controlled flight into terrain? That means you take a perfectly good airplane and you fly it right into the ground, right into a mountain. It's a flyable aircraft. It's just that due to a lack of coordination, due to a lack of teamwork, due to a failure of leadership or followership, that plane or those individuals are no longer with us. There's a great deal to be learned from CFIT accidents, but let's take a step all the way back to those very clever bicycle mechanics, the Wright brothers. This goes all the way back to our very first aviation fatality, which was Lieutenant Tom Selfridge, who was killed in a plane that was piloted actually by Orville Wright, one of those two clever bicycle mechanics. And what happened in this very first, if you want to call it that, root cause analysis of this very first aviation fatality was they looked at all of the contributing factors. Well, they knew that the plane had flown earlier that day with one lighter weight passenger. Why was it that when they had two heavier passengers that had crashed, that they found eventually that there were guy wires that couldn't support that weight? But the effort that went into understanding this very first fatality planted the scene that has been fertilized through all these years in commercial aviation and flight safety for the past 100 years, in fact. This gets us to where aviation and medicine start to come together. Now here's a cover from the 2000 British Medical Journal article where we started pulling together some experts from aviation and from healthcare to look at where are the commonalities in these fields. There are places where the analogy is powerful and there are places where it breaks down, but suffice it to say that if you just look at human nature and human performance in high-risk, high-reliability industries, there are some powerful lessons to be learned from looking outside of healthcare. And in particular, when we look at commercial aviation, the 70% of accidents that are breakdowns in human factors, it's not that the wings fell off, it's not that the engine blew up, it's not terrorism, it's not weather. The reasons that these planes are crashing is because they're complex systems in which humans have to interact with each other and with technology to pull off some pretty complicated tasks. Does this sound familiar? Here we have breakdowns in leadership, communication, breakdowns in ability to monitor and challenging your colleagues, breakdowns in decision making. And what happened is the industry, the aviation industry, welcomed research. They opened up their kimono and said, come look at us, study us, tell us what's wrong so that we can fix it, and these problems won't happen next time. Where we can learn from this in healthcare in particular is that we can't always have a randomized clinical trial to point us in the right direction for a new quality improvement innovation, but we need to pay attention where there is the strong research and the evidence to support the right way to do things. We have to do a much better job of making it easier for people who are busy and tired and cranky to do the right thing. How do you make it easy to do the right thing? We have to do a better job of that in healthcare. So here are the factors that set us up, right, for a fall in healthcare. We have problems with staffing and workload, equipment. We've got a lot of fatigue. We kind of set our caregivers up wonderfully for a lot of sleep deprivation. We don't give them the training that they need. There's poor coordination of care between shifts, between disciplines, between departments, between units. We have all kinds of production pressure. We don't even have to go into that. Some of us don't like our boss. That's not uncommon. There's a failure of policy. Do we have a policy? Do you follow the policy? Do you know about the policy? Do you agree with the policy? There's a lot of work that can be done just in that area alone. The physical environment, distractions, interruptions, right? Do we have enough space to do our work? Are there too many, is there too much noise in the environment to kind of concentrate? And then just patient condition, patient language issues. Health literacy. I mean, this is amazing stuff. The health literacy piece of it is fascinating. You know that 20% of your patients, 20%, cannot even read the headline of a newspaper? 20%, 1 out of 5. Are you thinking about that every time you interact with the patients? So this is a system full of complexity, full of factors that you're going to inherit at the front end, and it's going to make it more difficult for you to do your job effectively. So do we understand safety as a system, or are we going to continue to blame things that go bump in the night on individual caregivers? That's not the right way to do it. So our current approach relies on perfect performance every time. That's not very reasonable. That's not very realistic. We don't pay homage to human nature, which is that we're going to get tired, we're going to get overloaded, we're going to get distracted and stressed out. That's human nature. We try to pretend like we can overcome that somehow by going to nursing school or by going to medical school or by just focusing on the patient and doing what's right for the patient. But the truth is, this is going to come back and bite you in the rear end eventually. You cannot deny those human nature issues. We work together as a team of individual experts. That's not very effective. What we need to do is work together as an expert team, because the nature of how we deliver care has evolved just so much in the past 20 years. If we look at how patients are involved in their own care, it's almost non-existent. And some units are better than others, but this is something we need to pay a lot more attention to in terms of the safety as a system. And finally, the legacy of what we've been doing to date has relied on identifying individuals, shaming them, blaming them, and then sending them back to training. And that punitive approach isn't very forward-thinking, and it doesn't build a lot of trust, and it doesn't build capacity in individuals. And we need to do so much more to build capacity in our caregiving community. But this is the system that we created, and the truth be told, the tradition of that system doesn't make it right. If you recognize this picture, the running of the bulls, the quote here says, "Just because you've always done it that way doesn't mean it's not incredibly stupid." So if we look at the current approach and what the impact that this is having on our caregivers, we are slowly dripping away all of our resilience in our best staff, in the very best of us, the people who are most passionate, they care the most about delivering high quality care and being there and having that patient perspective and making it patient-centered. It's those people who are most vulnerable to burnout. They're the people in whom the joy in delivering care is being diminished. That's bad. We're breaking the best of us. Resources are wasted in a profound way. So for someone to say that high quality care is more expensive, all the research just begs to differ, right? What we find is that the most fiscally successful hospitals are the ones that have very strong safety and quality programs. And then lastly, needless harm is caused in this current approach. Because what are we doing? We're waiting for problems, and then we're coming up with lots of explanations for kind of explaining it away, rather than understanding what's causing the problems and eliminating those problems at the source. So what can we do? Let's take a little trip through stress and understand where stress comes from and how this affects our ability to deliver safe care. The gentleman here is Robert Sapolsky, who does this research. He's the one on the left-hand side here, Robert Sapolsky. And he's been studying the baboon analog for humans for 28 years, I believe, in the Serengeti. A fascinating guy. He's shown that all stress comes from two primary sources. If you cannot predict it, it can cause you stress. If you cannot control it, it can cause you stress. Those are the two sources of all stress. Now, this is important for quality and safety because all the interventions, SBAR and briefings and checklists, all these things that we do to improve quality and improve safety, what are we doing? We're just trying to make situations a little bit more predictable or seem like when the you-know-what hits the fan, it's a little bit more controllable. We have a plan. We know that when X happens, we're going to do Y. That's all we're doing. So let's go back to the biological model here and just say, look, stress comes from things that you can't predict or you can't control. Not only does it come from those two sources, but it comes from things you perceive you can't predict or perceive you can't control. Even if you can predict it, if you think you can't and it's happening, it's stressing you out. You're going to make bad decisions because of those perceptions. So let's take a quick tour through his summary of stress and the effect that it has on humans. He says, stress can wreak havoc with your metabolism, raise your blood pressure, burst your white blood cells, make you flatulent, ruin your sex life. And if that's not enough, it can even cause hippocampal atrophy. And we all want our hippocampus intact. It's good for memory and balance, all kinds of things. But this is a wonderful book that he wrote about stress if you're interested, called Why Zebras Don't Get Ulcers. It's a good read. He's a great writer. And it helps you understand where essentially a lot of these quality problems can be addressed is by improving the perception of control and the perception of predictability by putting in some safeguards for human nature. So how many of you guys in the past week, how many of all of you, could answer yes to any or all of these questions? Have you skipped a meal in the past 7 days? Have you eaten a poorly balanced meal? Did you work an entire day or an entire shift without any breaks? Hey, did you change your personal or family plans because of work the past 7 days? Yes. Get home late from work? About 80% of us get home late from work, and only about 15% of us get to work late. What does that tell you about work-life balance? How about drink too much coffee? Yep. And if you have to ask, how much is too much? Come on. Slept less than 5 hours in one night. Every one of you, right? In the past 7 days, every one of you have gotten less than 5 hours of sleep in one of the nights. And what do we know about this? The research has shown that over 40% of Americans fall into this category of once a week getting less than 5 hours of sleep. And those of us who fall into that category, myself included, you are twice as likely to die of heart disease and 1.7 times as likely to die of all causes. Yep. So to say that, oh, suck it up, sleep deprivation, that's what residency's for. Oh, sleep deprivation, if you can't handle it, what are you doing in nursing? That's just wrong. In fact, the guy who does this research, and I couldn't make this up, his name is Francis Cappuccino. Isn't that lovely? Cappuccino. So this is what's happening, right? This is not just quality as measured by an infection rate or number of errors or by some operational metric like nurse turnover or delays. This is quality as measured in the way that we interact with each other, that we interact with ourselves, and the way we interact with our patients. So let's look at how this has an impact on frontline caregivers specifically. Now, this is research actually by my wife, so if you see that name Sexton, that's not necessarily myself. But she showed just this last year in palliative care that half of critical care nurses fit the criteria for emotional exhaustion, right? Burnout syndrome. Half. 2 out of 3 of them have difficulty sleeping, and 1 out of 4 of them meet the criteria for clinical depression. So if you're wondering what percent of the population, the general population, meet the criteria for depression, it's between 6% and 8%. But for critical care nurses, it's not 6 to 8%, it's 1 out of 4. That's crazy. This is crazy. What are we doing to our caregivers to create these environments in which they can't thrive as people? So let's look at a redefinition, right, of what we mean by quality. Quality isn't just how we take care of our patients. It's how we take care of each other and how we take care of ourselves. You need to go to the bathroom? Did you go to the bathroom last time you needed to go to the bathroom? When you got hungry at work, did you stop and eat? You can burn the candle at both ends for a little while, but not for very long. So eventually your ability to deliver 100% and give every ounce that you have to your patients is diminished. And then what's happening to quality? When we're not taking care of ourselves, then we're not taking care of our patients. So we have to do a better job of seeing this more holistically. Let's take a look at labor and delivery for a minute. This is published in the Journal of Perinatology a couple of years ago. And we showed that in looking across 44 labor and delivery units, and the norms in these 44 labor and delivery units, which range from about 15% reporting good teamwork to 75% of them reporting good teamwork. Each bar here is a different labor and delivery unit, and it represents the percent of people in that L&D unit who report good teamwork norms within that unit. So up from 15% to 3 out of 4 saying that I've got good teamwork in my labor and delivery unit. What was interesting is not just that there's a lot of variability from one unit to the next, but what that's associated with. We found that the folks down here, where you're not reporting very good teamwork in your L&D unit, they have less predictability from moment to moment. Everything seems like it's a surprise. That's not good, because what does that do? That causes stress, right? If you can't predict it, can't control it, causes you stress. These guys are really stressed. Not just is it bad teamwork that you have to endure, but it's more stressful. They don't know who they're working with, so there's a lack of familiarity. I don't know the names of the people that I work with. I don't know what their work styles are, so there's a lot less predictability in that sense as well. Down here, we've got a lot more burnout. Over here, there's less burnout, but down here, we've got a tremendous amount of burnout, emotional exhaustion in these units, right? More delays down here, fewer delays on the right-hand side, and very poorly coordinated shift changes, so transitions of care, handoffs, mid-shift and shift change are done very poorly in units where there's poor teamwork. So we're learning a couple of things from this research. One is that teamwork varies tremendously from one unit to the next. You might have a Shangri-La of teamwork right here, and you walk 20 feet down the hall into the next unit, and it's a cesspool, right? So it varies tremendously from unit to unit. It's not a hospital phenomenon, it's a unit-to-unit phenomenon. Burnout also varies tremendously from one unit to the next. So we have to stop thinking about people who are burned out as just being failed or broken individuals. These are individuals who are vulnerable to burnout because they care so much, because they try so hard. It is because of their passion and tenacity that they are vulnerable to burnout. And we're setting them up in these units where the teamwork isn't good. Because what happens if you don't have good teamwork in one of these units? What do? You don't feel comfortable speaking up in your L&D unit? You go through the whole day trying to just bite your tongue. You go home and you get in a fight with your loved ones. That's not good. Right? You get in arguments with your neighbors. You stop calling your relatives. That's not good. So this is what we're doing. This is where quality at work and work-life balance and burnout all start to come together. We have to redefine quality to include also how we take care of ourselves. So in terms of the unit-to-unit variability, you might work in one of the units that have really good quality, really good safety, really good teamwork, not very much burnout. But you might be just down the hall from one that does that very poorly. Safety norms vary significantly from one unit to the next. Burnout varies significantly from one unit to the next. Quality varies significantly from one unit to the next. And what do we have to do to build capacity? We have to do a better job of working with units to become learn-how units. I think there's a misconception that many of us have, myself included, that if you just look at the literature, you'll find the randomized clinical trial that explains how to fix this problem. The truth is, we don't have the randomized clinical trials to show us how to fix quality in healthcare yet. We're a long way away from that. So we have to get staff not to look up the literature, or to find a meta-analysis, or to get a best practice from some journal that's a reputable journal, because largely they're not yet there. And instead, we have to do the learn how. Do the best you can in terms of finding out what's the right thing to do, but the units that are most successful in implementing quality improvement and sustaining it over time aren't the ones that can quote all the literature. They're the ones who are aware of the literature, but they focus much more in how to implement that in a unit under resource restrictions and limitations on staff, limitations on equipment and supplies, budgets. Finding out how to do what you think is the right thing in your context, that's the key. Those are the units that really thrive and survive and sustain it over time. So there's a tremendous amount of variability. If you just look at 30,000 people across the Ascension health system in 890 different clinical areas, it ranges from, and this is 890 bars, right? 890 units across Ascension Health. It ranges from 0% of the people in a given unit reporting good safety norms all the way up to 100%. So where do you work? Do you work in one of these units where you wouldn't feel comfortable using the incident reporting system because no one's going to do anything about it? Or do you work in one of these units where not only do you use the incident reporting system, but you know that your input's going to make a difference in how patient care is affected in your unit? The folks down here are saying, my suggestions about safety would be acted upon if I expressed them to management, and the folks down here are saying, I'm worried about my mortgage, I'd rather say nothing and just hope that it works itself out. What a horrible position to put frontline staff in. Where do you work? So if we look at how to improve reliability as a science, and you can take lessons from the manufacturing sector, you can take lessons from the military, lessons from commercial aviation. The truth is, we have to do a better job of reducing complexity, knowing when we're doing things that we're not supposed to be doing, right, and measuring that, and learning when things go wrong. If there's a defect, if there's a problem, something goes bump in the night, we have to know how to respond to that. And what happens now is people are so scared so often that they'd rather look the other way and hope that they don't get associated with the problem than jump in to help to solve the problem. So we've set up our caregivers for a horrible fall. And all the best quality organizations invest a tremendous amount of time and energy into helping caregivers know how to respond to problems, these defects, when they occur. And these defects could be anything. It doesn't have to be a sentinel event. It could be any kind of equipment problem, any kind of a staffing problem, any kind of any issue that you don't want to have happen again, that you put that in the defect bucket. So the defect occurs, what do you do about it? So we have to learn from our defects to move forward. And the problem is, the way we've talked about it so far is we're saying defects are too expensive, right? It's making us feel bad, right? It's too intimidating. I don't know how I can possibly, just little old me, fix this big broken system. The truth is, these defects are far too addressable for us to ignore. And we're missing out tremendous opportunities to go in, fix it, and say, I made patient care safer at the bedside today because of what I did. I had a good day today. All too often, you get to your car at the end of the day, you put your key in the ignition, and you say, I didn't make a difference, but I sure worked hard today. I don't know how many more days like that I can handle. Then you turn the key. That's what's happening too often. We're missing tremendous opportunities to build capacity, to feel a sense of control. You see something that's broken, you know how to fix it, you jump in, guess what happens? It was a hard day, but you go home feeling like you made a big difference. That's how we can put joy back into work, is to give that sense of control back to frontline staff. These defects are expensive. They're causing delays in the delivery of care. They're causing prolonged stays. They're causing death, all kinds of increases in morbidity, mortality. So to ignore it, when just solving it can bring such a multifaceted solution to our caregivers, is just a travesty. So I'll harken back to this Chinese proverb where, if you tell me, I'll forget. If you show me, maybe I'll remember. But if you involve me, if you make me a part of the solution, then I understand. And that's where we have, as a healthcare system, failed our frontline staff, because they want to be involved. They're not given the tools. They're not given the training. They're not given the protected time to make a difference. And slowly, slowly, we're dripping the joy out of their day-to-day care delivery. So here's an exercise. If you can say this and feel like it means something, you'll know that you have come out of the doldrums of one of these kind of burnout units, one of these low teamwork, low quality units. My job is to find and fix defects so that we deliver the safest care in the world. You go to General Motors in Detroit, and what do you find? You ask somebody who works on the assembly line and say, what do you do? What's your job? And that person will look up at you and say, I'm putting the door on the car here. That's my job. I do that all day long. You go to Toyota and say, the same person, that same position on the assembly line, what do? I'm building the safest cars in the world, the best cars in the world. That's what I'm doing. We have to find that again in healthcare, because we've lost our way. We've put too many hats, too many pressures on frontline staff who have too many responsibilities, and they don't have the time, they don't have the resources or the tools or the training to really be able to do this in a way that's meaningful to them. So where do these defects come from? You can look at your incident reporting systems, your sentinel events, you've got claims data, you get infection rates, you've got complications, and first and foremost, you can ask each other, right? This is where we miss out on opportunities where nurse managers, unit managers, medical directors can go to frontline staff and directly and say, how is the next patient in this clinical area going to be harmed? What can we do to prevent it? Start the conversation. How do you respond to that, though? Let's look at this tool here real quick. It's called Learning from Defects. Okay, the Learning from Defect tool. First, you start with the defect, and you have to answer 4 simple questions. Right, and this defect can be anything. It could be clinical, operational. It's just something you don't want to have happen again. And you answer these 4 questions. What happened, briefly? Second, why did it happen? What made it not as bad as it could have been, and what made it worse than it should have been? Right, what contributed, positive and negative? And the third one, and this is really important. This is where if you get it, then you can take this. You can take this tool and do powerful, powerful things in your unit. That is, what will you do to reduce the risk of it recurring, in particular with different caregivers? So this is what Jim Reason calls the substitution rule. If you can take this event, this defect that occurred, if you take all the people that were involved out of the equation and you put random other people in their places, if it could happen again, you didn't fix it, right? The root cause isn't addressed. So how do we prevent recurrence with different caregivers? That's how you fix the problem. Once you get that, you can do powerful, powerful things in your unit. And then the 4th step is here, how will you know that the risks were reduced? Is there something that you have to measure? Is Is there something you need to audit to make sure that you did what you thought you did? These 4 simple questions are very powerful. If you can master this, you can start to own quality again in your unit. So here's the tool itself. It just goes on your badge, right behind your ID badge. And it lists out what happened, why did it happen. It gives you examples of the system factors that we covered earlier, right? Production pressures, equipment problems, workloads, right? Patient condition. What can we do to reduce the risk of it recurring with different caregivers? How you know that it's reduced? And the last question here on the card, just as a prompt, because this is where we mess it up a lot, right, in implementing this stuff, is with whom should we share our learning, right? We talked about the cesspool and Shangri-La right down the hall from each other. This is how you start to break down those silos of excellence, because we have to say to ourselves, you know what, we went through the 45 minutes it took to break down the root cause of what happened with this defect and start to talk about what we can do to prevent recurrence. We took the time to figure that out. We have a lesson learned here. With whom should we share that lesson learned so we can spread that around? And there too, there's a tremendous sense of joy in figuring something out, solving a problem, and sharing that with your colleagues for whom it's very relevant so that they don't have to go through that same process that you did. And as we're closing here, I just want to say we have to accept in the healthcare system that we're going to make mistakes. We have to focus on the broken systems rather than blaming individuals, because blaming individuals, we're bleeding out the best of our staff with this method. We have to focus on the patient rather than focus on error. You can count errors all day long, but that doesn't necessarily make things safer. We have to create clear goals, and in particular, if you've got a question, you need to speak up. Speak up as early as you can. Now, I can say that. That doesn't mean you're going to do it, but we'll talk about the speaking up we'll talk about the speaking up coaching session here in just a second. We have to standardize, create independent checks, right? Learn from our mistakes. And creating independent checks, what is that doing? You're just introducing a little bit more predictability into the process, right? Standardizing. So what's the summary here? Patient safety as a system is about changing situations, which is a heck of a lot more effective than changing human nature, because human nature is always going to be there lurking, waiting for an opportunity to come out. So to give you a quick overview of what we do at the Patient Safety Center here at the Duke University Health System, and here's our website if you're interested. We offer patient safety officer training in physician leadership in safety and quality. This is how do you give bad news, how do you lead in safety and quality efforts. For executives, we offer the same thing, right? For physician leadership, executive leadership. We have safety as a system. That's what you just watched just now, perspective from the bottom up. We offer team steps training, and by the way, if you don't know this already, Duke is one of 5 team steps training certified training centers around the country, and it is in high demand. People from all over the country ask to come to Duke to get this training. So if you're interested in team steps training, lucky you, because Laura Maynard, the lead faculty there, she does a really good job with that for team steps training. There's the short course if you just want a quick overview of what it's about, and then there's the full implementation where you train the trainer and you teach others how to carry the course forward. Conflict resolution coaching. This is important because we don't usually get training in this, and if we do, it's by people who don't really understand what it's like to kind of resolve conflicts in nursing units. And bouncing back from burnout. We have an overview, which is an introduction to how burnout and quality are related and what we can do to kind of build more resilience into the system. And we have the intervention, which is designed to help people recover from burnout, whether it's individuals or units. This gives you a sense of the kinds of trainings that we do at the Patient Safety Center. I hope you enjoyed the presentation today. Please don't be shy. Come visit us at the website and be safe.